Hey, everybody, welcome to Off the Cuff, all things healthcare. My name is John Kublank, and I am one of your hosts today. I wanted to make a short announcement that we have the Agile Growth and Innovation and Leadership Experience coming up on the 17th, 18th, and 19th of April. So it's right around the corner. And if you use Maxim 100, you will save some money at checkout. And everybody likes to save a little bit of money. We want to give a shout out to Gateway Home Health and Coding and Consulting, and also Narcex for being our sponsors. So we have a really, really special show for y'all today. And I, as always, am excited to be here with my co-host, the wonderful, extravagant, but always subtle. Just her amazing is always subtle, but you know that it's there. Miss Arlene Maxim. Thank you, Arlene, for being here with me and getting this together.
Well, thank you, John. And we do have an exciting program. I've been doing home care for a very long time, as you all probably know. And for a number of years, I was a home care nurse. So I actually went out, I saw patients, I did documentation. I've even done OASIS for some folks that might not think I have. And one of the frustrations I had, and it continues to be a frustration after all of these years, is the amount of time staff take in doing documentation. So we see our patients, then we see another patient and another patient, another patient. We see 6 to 7 patients a day sometimes. Then we go home and we have to continue with our jobs in doing the documentation. So I have the extreme privilege of introducing Jason Banks, who is the Vice President of Business Development for nVoq. And he's going to talk to us about a secret he has in getting documentation done very quickly by voice recognition. With the shortage of staff we have and with problems with work-life balance that clinicians have on an ongoing basis, Jason brings to us something that every single clinician that does home health care will want to look into. So Jason, I'm going to go ahead and turn it over to you, and John and I will certainly have questions for you, but I'll go ahead and let you do an introduction of yourself.
Sure.
Welcome, Jason.
Yeah. Thank you, John. Thank you, Arlene. It is a pleasure to be with the both of you, and I can't wait to meet you in Dallas one short week from now. Looking forward to the trip down there. As Arlene mentioned, I am the Vice President of Business Development for nVoq. We are a speech recognition provider. The company has been around over 20 years, actually. Just got involved in home health and hospice probably 3 short years ago, though, and sort of taken off from there. We're now have the good fortune of working with agencies all across the country. They range in size from 20 clinicians to 20,000 clinicians. And yeah, you're right. Our primary goal, our North Star, is to give clinicians their lives back, to allow them to get back to a level of satisfaction and pleasure that they got for the reason that they got into this industry in the first place. You know, I say a lot of times when, I'm speaking at conferences, home health and hospice clinicians are different. They're special. And the reason they are is because they get into this industry because they love caring for people, but not only caring for people, but they do it in complex environments in their home, which creates a whole different set of dynamics. They also thrive on relationships. And so, in a acute care setting or an ambulatory setting where it's very transactional, home health and hospice clinicians are really awesome and thrive on personal relationships with those patients and families. They many times, and my father was a testament to this, they become like family members themselves. And, it's really, truly wonderful to watch. The challenges over the last, I don't know, Arlene, probably 15 to 20 years, it's gone from providing space for those relationships to be able to be built and the flexibility that clinicians used to have, which is part of the reason why they would go into home health and hospice, to something that's become a true burden for them. And it's putting a barrier now between them and the patient, and ultimately why they got into this profession to begin with. And so nVoq helps a lot with that. I thought coming into nVoq probably close to 2 years ago now that we were just a SaaS company providing speech recognition solutions. And that is true, but we also have an impact on every area of the organization, from revenue optimization to QA to retention and recruiting to change management within an organization. We're a non-compulsory product in many cases, meaning, the agencies aren't requiring their clinicians to use it. And so you'll see, there's a majority of the clinicians that pick it up and they use it right away. It's something that they've been sort of waiting for, didn't know they were waiting for, but they're waiting for. And then you have other clinicians that just don't even have the space and the time, even if it only takes 15 minutes to learn something new in their own best interest. And so it's how do you get organizations to lead them down a path of change management that's going to benefit the clinician, the patient, the organization. And so we've sort of become experts in that area as well. And obviously the partnership with Access is a huge boost to that, because Access is focused on organizational change management. They're focused on retention of clinicians. You talk about the education programs that Access puts forward. So all of those things we think just create a real solid partnership for the two of us. So hopefully that gives you a bit of background. My background, myself, I've been in technology and home health and hospice for 20 years. I had the good fortune of running a hospice and palliative care here in Chicago for a number of years as well. And so really got to work and support and serve those that serve others, which was truly rewarding. Really enjoyed every second of it.
Well, thank you. And you're going to be one of the featured speakers at Agile that John mentioned earlier that will start next week, a week from today. Mm-hmm. And isn't that incredible? The time just went by so fast. We started planning this a year ago. Agile's, the planning stages started a year ago, and here it is, right on top of us. So we're really excited to have the conference and be there at the conference. And Jason, you're going to be a huge addition. That work-life balance. Can you talk a little bit more about how much time? What's some of the data that you have on the time savings that clinicians might experience if they're using nVoq?
So it's a good question, and one that we get asked often. It's one of the first questions that we get asked whenever we're engaging with a home health or hospice provider. And what I usually tell people is it depends, quite frankly. It depends on the role and the type of visits that those individuals are making. On average, if you're a routine nurse or a PT, OT that is providing care either in a home health or hospice setting, the average savings is about 45 minutes to 60 minutes per day. If you are an admission nurse that has much more narrative-based documentation on a per visit basis, the savings could be anywhere from 90 minutes to 2 hours.
Wow.
The question that I often get asked, particularly by executives when I start to talk about those numbers, is, am I going to see higher productivity of those nurses, or am I going to see a direct cost savings? And the answer is sometimes, but not always. And let me explain why. So in home health and hospice, if the organization is paying the clinician on a per hour or per visit level, sometimes you will see a productivity increase. In some states, they're required to pay clinicians for after hours documentation. And so, yes, there will be a direct line savings by cutting down that documentation time. But sometimes that time manifests in other ways. So particularly if the organization is paying their clinicians a salary, and how it manifests itself is in more time with those patients. And that ultimately can result in better CAP scores, better outcomes, those sorts of things. It also, we have a number of studies now that show that the number one driver pre-COVID of turnover within home health and hospice was after hours documentation and after hours charting. And so we're drawing the link now between retention of those so valuable clinicians that serve these communities and after hours documentation time. So it doesn't always mean that, you're going to see a bump from, 5 RVUs to 6 RVUs a day for a routine skilled nurse, or be able to get them from a 15 caseload to an 18 caseload. It doesn't always mean that, but what it will mean is more satisfied clinicians, and we see that across the board because we start to survey those clinicians on an ongoing basis to figure out how satisfied they are. And ultimately, we believe it's going to be result in higher CAP scores. And the reason I say that is because I've done a little bit of research on CAPs. And there is one key question in the CAP score that drives all other questions. And that question is, how do you feel about the care that was being provided to you? And it's based off of how that patient and family feel about the care that dictates their response to every other question within the CAP score. And that feeling is directly related to, is that clinician present with me when they're actually in the room or in the home? And so, again, I thought I was getting involved with a speech recognition company that's just SaaS-based, and we're touching all areas of the organization, including patient satisfaction.
So do you see that there's an increase in the willingness to do point of care documentation when using voice recognition, therefore improving the quality of the documentation because you're getting real-time information about the patient, as opposed to 10 hours later when you're so tired and you're trying to get your children in bed and you still have to do documentation. So you do the best you can, you remember as much as you can. Those little notes that the clinicians keep, the therapists and the nurses and the social workers keep by their side as they're watching the patient do their ADLs or whatever they're watching them do, and then taking them home with them and writing their documentation, it's not HIPAA compliant. And I don't think clinicians even think about that. The HIPAA compliance isn't even a thought that goes by with them keeping those little notes. With the voice recognition, it would seem to me that you would improve HIPAA compliance. You would improve survey results because you're doing whatever, you're talking and documenting whatever is going on with that patient, and you're going to improve reimbursement. So when you have medical reviews, you have real-time documentation, you have real-time data that you're using, and you're able to show that to medical reviewers.
That's exactly right. Yeah, I mean, you touched on all of the salient points, and there's a ton of studies out there that show that the time proximity to the documentation makes a big difference in the accuracy of that documentation. Right. We still see a lot of change of practice with clinicians documenting at the bedside. But I'll tell you, the more and more we implement this, the more and more feedback that we're getting from clinicians that are saying, you know what? I introduced this voice recognition as a new tool that I'm going to be using to document the encounter that I have with a patient. And not only with compliant patients, but with non-compliant patients. For the first time ever, those patients are hearing what's going into the medical record. Mm-hmm. And so the patients are saying, no, you got that wrong. Or they're hearing the clinicians say that the patient is, in a very kind way, non-compliant with some of the treatments, and it's changing the way that the patient is now interacting and connecting with that clinician. So it has multiple different, positive streams that come out of that. And again, we sort of are this, we have a great tool. It is rock solid, but we have also a great customer success team, and they lead our clients, our clinicians down a change of practice sort of path that is truly beneficial for them to go down with or without the technology. So, we have a lot of conversations about bedside documentation and charting. We have a lot of conversations about what is high quality documentation. How do you tell a patient's story? We interact with a lot of clinicians out there, tens of thousands, in fact, that they are so good at bedside care. I cannot tell you, Arlene, how fantastic they are. But many of them don't know necessarily how to structure that patient's story in their head because they're so used to point and click, drop down boxes, sort of the robotics of discrete data elements. So when you ask them to tell the patient's story, they have a somewhat difficult time of structuring their thoughts. You think at 1,200 words a minute, you can speak at over 100 words a minute, but you can only type, usually most people in a medical term, about 30 to 35 words a minute. That's really it. So their ability to tell a story in a conversational way is super helpful. So what we provided them, in addition to the speech recognition software, is a cue card or an outline to tell the story. So when they're in the patient chart, we actually tell the home health or hospice clinician, here are the 6 things that you want to tell about the patient in your experience with them. And then the system will tell them, yeah, you got them all right, or you missed one, go back and chart that again. Because if there's one thing clinicians hate worse than after hours documentation, it's getting the documentation back from QA saying it's not correct, go do it again. And so, yeah, it's just, it's been a wonderful experience. We learn from our clients, they learn from us, and we both get better because of it.
Well, with all the changes with the federal government, home care just within the last number of months initiated the notice of admission, the NOA. Of course, hospice has had that notice requirement for some time. But with that, it would seem that with that voice recognition and getting that real-time information on site with that patient, that's going to improve those statistics for sure. And again, the reimbursement. When I teach documentation too, I talk to folks about, you don't have to only be worried about surveys, your state survey or your accreditation survey, and your medical review process where the contractors, Medicare contractors are going to come and ask you for more information. That document is a legal document. And if you're putting down something that you can't remember a year from now or 2 years from now, when this case may go to court, if they happen to do that, how are you going to remember what actually happened? If you were sitting in the home 10 hours after you got done work, or not 10 hours after you got done working, but after 10 hours of work, with your kids wanting to go to bed or needing care of some sort, and you're trying to remember everything and recollect every single thing you did during the day, that's not going to work, and you're not going to remember two years later. So getting that, like you said, with those important pieces, seems to me that the QA people would love it. It seems like the quality assurance folks would just absolutely love it.
They do. They love the fact that, the clinicians, because, clinicians want to do a good job at everything that they do, right? And so they want to provide the best level of care. They want to provide the best level of documentation. But it's human nature, right? You sort of put off or delay the things that are the most painful, which is why you see most clinicians doing all of their, or a substantial amount of their charting, at the kitchen table late at night. And so, if we can give them the tool to at least get it out into the medical record in real time, you're right, it benefits. And now you've got TPE, which is so easy for the government to request records, and and just because they're curious about it, and then you have to sort of, to your point, go back and figure out, is the documentation complete? Is it defensible? We talk about defensible documentation all the time, right? And again, this is another sort of learning point with clinicians, is when they're dictating, when they're documenting, many of them are just truth tellers, right? And that's great. You want clinicians to be open and honest, but sometimes you need them to paint a picture in a way that doesn't leave patients behind either, right? So for instance, in hospice, the patient's symptoms may be stable. Well, that's that's not uncommon in hospice, but that doesn't mean that the patient isn't still declining, right? And so you talk to the clinician about, how do you still paint the picture of a declining patient whose symptoms are still stable? And so, it's really, truly rewarding, because I think we are making a difference in, not just those clinicians' lives, but patients who, again,
families
maybe kicked off of service because from a piece of paper, it may look like they're stabilized or even getting better when they're absolutely still declining or at least needing help in certain areas.
Administratively, John, what are you thinking?
Well, I definitely see, there with more and more regulation and efforts for compliance, and that technology on the government side is always increasing, right? You said TPE, but just their ability to analyze the data like a lot more quickly and accurately. You have to be able to find more economies of scale out of your labor without reducing your quality of care. So if you are not looking at documentation as that place, then you're either giving up the quality of employees that you're doing, or you are going to burn them out eventually. That is it, because we can't get away from the compliance. The documentation is key. And what I think, Jason, what I keep hearing is we're doing documentation at least twice, if not 3 or 4 times.
That's right.
We need to be doing it once and moving on, because it's already hard enough in this space to take care of patients. I in the hospice area, in the arena, they never an issue Monday through Friday, 8 to 5. It's always after hours. It's always on holidays and weekends. And so to be able to focus on the patient, to remove the really the burden off of the clinician, will provide that really the quality care that everybody's looking for. But Rob Drew had a question, wanted to ask, not sure if I missed this, but does this work with all EMRs, electronic medical record systems currently, or which ones do they work with, Jason?
Yeah, obviously we have a partnership, very close partnership with Access. We'll be at the Agile conference next week, but it does work with a variety of EMRs. It's an overlay. Usually it's an operating system that we install on. And so you can use it in the EMR, but you can also use it in things like email as well. And so that really speeds up that process too, as you're looking at how do I leverage the tool for more than just the EMR, because we know how many emails are flying around home health and hospice organizations on a daily basis. They're substantial.
So run us through that with the email. What does that look like? Is that just responding to the email? Is it, and is this an earpiece that they're using, or what's the microphone that they're using?
So good question. On Windows, it would be more of, a USB connected headset, or they can use their cell phone. It can be iOS or Android devices, or if they're using an Android tablet, we use the inherent microphone on there. They don't need any special equipment. They just hit the microphone button. So, on Android devices, for instance, we replaced the Google keyboard with our own. On a Windows device, we have a persistent microphone that you download, takes about 5 minutes. A clinician can train in 15 minutes. That includes practice dictations, and they're up and running. So, it's interesting because we're able to do really robust proof of concepts where we deploy this to a handful of clinicians, allow them to use it for a couple of weeks. I often caution the provider side and saying it's going to be hard to rip out of your provider's hands once you give it to them. So that's my hook to get in there. But to your point, John, I think the reality is that you can use this across the organization. I really think that documentation is one of the few areas where I often talked about a patient tax. So there are things that the clinician must do for regulatory compliance and for other reasons that are truly a tax on the patient. They're a burden on the patient. One of those is documentation. I'll give you an example.
Amen. Yes.
Oftentimes we had hospice clinicians that were documenting 30, 40 meds 3 times. They would document them in the EMR. They would put them in a nursing home chart, and then they would put them in a home chart for the resident or family to also be able to view. And so, I saw this happen so many times where the clinicians would tell me it's impossible to sort of keep those reconciled and to keep up with the volume of documentation. But I would also have the same level of conversation around drive time, which is another patient tax. And so I know Access is doing things around that as well, around routing optimization and optimal scheduling and things like that, those are truly patient taxes that may not necessarily add a whole lot to the patient experience. And so I really see us as one of those key things that can be taken off the clinician's plate. And there's not many of them, to John's point, that we can go address beyond going and hiring, perhaps a lower level skilled clinician like an LPN or something like that to perform, primary nursing duties. And so, we really feel like this is important to allow clinicians to continue to operate at the top of their license. We think it's important as organizations start to look at value-based care. These Medicare Advantage plans are not going to be able to provide reimbursement for tons of after hours documentation for the clinicians. And they're also going to start really looking at productivity of clinicians as a true measurement. And so those sorts of things are going to come to bear.
So I think a lot of times in the administrative position as well, everybody is always kind of saying, well, can I take a shortcut? There's already speech to text on HCHB or Access where I hit a button and it translates, or maybe I can use my phone. Why can't I just use that? It's already on my phone. How does nVoq, how have y'all really centered in around that healthcare, lingo or,
So there's really three main components that would separate us from a commercially available product. One, and the most important one we all know, is that ours is HIPAA compliant, right? So the number one, thing that is on the top of mind for every home health and hospice provider is to make sure that they're in compliance. Because if they're not in compliance with HIPAA and all the other regulations, doors shut, mission closed, game over, right? So that's number one, we're HIPAA compliant. Number two is that we have built the data dictionary and the user experience for home health and hospice clinicians, those remote clinicians. And so them being able to use their tablet, to use their phone as the microphone, those are super powerful things. In addition to, I tell people it's 95% accurate out of the box, and it just gets better from there. Many of our clients are over 98% accurate. I encourage you to go look at what typing accuracy is not as good as 98%. And also, I think another factor is that, we built functionality on top of the solution. So we have a feature that's called Note Assist, which is sort of that cue card or that outline for the clinician to be able to know how to tell the patient's story, what to dictate in there. And it also provides us the QA mechanism to make sure that they got it right. So there are features and functionality that we built on top of the speech recognition engine tool that are extremely valuable in a home health and hospice environment, and ones that you won't find in commercially available products.
This is probably isn't a good question, but could a nurse contract you to get this independently, or does it have to go through the agency?
So today it has to go through the agency, but there is a certain path forward that we are leaning into, which will enable clinicians to potentially be able to either get this on their own or deploy it on their own as a truly sort of app-based experience. So we're not quite there yet, and but we're getting closer and closer to that. I will still say there is tremendous value in our customer success team engaging on change management with the provider level. And so that really has driven a lot of the adoption of the platform. But I think to your point, Arlene, we're seeing more and more, contract agency or independent,
Yes.
Clinicians that want to work on their own time schedule and bring their own devices to work and be able to do that sort of a gig economy approach. And so that absolutely is something that nVoq is leaning into.
You're looking at, that's interesting.
Yeah, absolutely.
I think one of the problems with home care, post-acute care that I've noticed in my 10 years that I've been a part of is that they're very resistant to change. And a lot of it, I believe, in my opinion, is around the compliance that we don't know, especially when it comes to AI or technology. We don't know if an auditor is going to come in and say that we're doing something wrong, or how does this all work together. And on top of that, like we know, you had said it earlier, change management, and even if it's just 15 minutes of learning something new, is already taxing on somebody that is at 110 or 120% of their bandwidth. How is nVoq, trying to, be, gently getting this product into the market, or how do you help administrators in organizations through this change?
Yeah, so that's a great question. First I'll say that, we often get CEOs or C-level folks. Again, I'll go back to the conversation around are we going to see an increase in productivity? And I normally say you may not, depending on how you pay your clinicians. Some of them don't like that answer, but I often tell them, and I've seen enough data to substantiate this. The vast majority of agencies that are paying their clinicians salary are paying them for 40-hour-a-week work weeks, and those clinicians are working 60-hour weeks. Mm-hmm. And so if nVoq reduces that time to, let's say, 45, 50 hours a week, gives those clinicians 10 to 15 hours of their time back, mm-hmm. then, you're not likely to see an increase in productivity. What you are likely to see is a happier clinician doing more point of care documentation, right? So Arlene talked about earlier, what's the alternative to this? The alternative is one of two things, as I see it. One is chart something on pieces of paper. Well, I have a 10-year-old. She can steal things on pieces of paper. It's not that complicated to do. And the second option is go by memory, right? I'm going to wait till the end of the day to chart on my 3, 4, sometimes 5 patients a day, and hope that I've sort of kept them straight in terms of what I remember my interaction being with those patients. So, I often tell people, that you're reducing your risk because it's so much easier to hop in the car, even pull up a notes section on your EMR and just document everything that's on your mind so you can clear the space in your mind to be with the next patient that you're going with. And now you've got it in near real time. Again, we still have clinicians, some of which do chart at the bedside, some chart as soon as they get out in the car or, the nearest, Starbucks or whatever. But I would contend that you have more accurate data, you have a better clinician experience, you're ultimately going to have a better patient experience. And so that all sort of goes together. It turns out happier clinicians equal a healthier organization.
One, your retention, like you mentioned earlier, the retention of employees is so important. We just don't have the number of, at least nurses. Now, therapists, that might be a little bit different, but at least nursing. I mean, we are in a crisis right now with the number of clinicians we have available. The other thing, we don't have nurses coming into the programs because we don't have nursing instructors. And that is, people need to stop and think about that. We have to take care of what we have. And that retention is just so important. Hiring, you can hire, but you don't know what you're getting for a long time.
That's right.
Having that retention available. And, like I said in the beginning, I think you have magic here, Jason. I think that this is an answer to an awful lot of issues that we have throughout the organization. John, you've worked in home care companies and hospice companies. What is probably 50% of our problems is documentation in an organization, at least 50%.
Well, I think it's 50% of the workload, probably at least, and it's probably 75 to 90% of the issues that we deal with, which, going back to Jason's point, it's like, we need to focus on our core competency. Nurses' core competency is taking care of patients. Really, the core competency of documentation, if you think about it at a high level, I've always said is a billing core competency, right? Or some sort of QA. Like, it's how you chart is really not attached to how well you take care of patients. And we push them together artificially because we say that makes sense. but we need to really let our clinicians focus on their core competency, which is taking care of patients.
Absolutely.
And I when I was an administrator for one organization, I looked at a lot of different tools to record or utilize different OCRs, or text to or writing to text or these sort of situations. Once you get the leaders buy-in, they say yes. Like me, it's easy. You've already sold me, Jason. If I was at the administrator level, if I was at the CEO level, I'd have bringing you in tomorrow. But where do we start after that? And how do you get everybody else on, the DON, the nurses? How does that start? Walk us through that process.
Yeah, so it's a great question, and one that is at the core of our change management process, because, again, it's, the leadership is often, what we get a lot of head nods from the clinical leadership. We get a lot of head nods from the IT leadership. Then it gets to a CFO level, and the CFO level wants to know what's the return and how do we drive adoption, right? And so what we found over the course of time, we're still getting better and better at this, is how do we engage those frontline managers, those clinician managers, the education managers? How do we enable them to bring this to the clinicians and tell them, truly paint the picture for what a future state looks like for them, not only for those existing clinicians, but for anybody new that's coming on board, that they might just onboard them with speech recognition as a normal course of practice that they follow. And that's made a huge difference to have your preceptors, your education directors, to have this as a part of their normal onboarding process, so that clinicians can take this day one. And because what we often find is that if you have a clinician that uses the platform in earnest for 2 weeks, they don't put it down, right? So it's the change management is, how do you help the clinician to create a habit, a 2-week habit? And then how do you continue to build functionality on top of it that just makes it easier and easier and stickier for them to derive value out of it? So think of it as like the Netflix approach, right? We're going to make this super easy for get your shows and your movies. Then we're going to add a ton of content that we know you love. And so that's sort of our approach, is give them a tool that's super simple, that's not going to take a ton of time. You don't need days to learn how to use nVoq, and then continue to make it better and better by listening to our clients and building what they want to see in there.
That's a good point. I'm sorry, John.
Oh, no, go for it, Arlene.
How much time does it take, and what's the educational process in using nVoq? Do you have staff that come into the agency, or do you do Skype, or how does that work?
Yes, so we usually have most of our deployments are remote. We have in-app training for the end user clinician that comes with practice dictations, but we are really high touch. Our customer success team is unbelievably hands-on, and we have a number of clinicians throughout the organization at all levels of the organization that really walk and guide the leadership through the change management process. But in terms of a time frame, again, it really takes 5 minutes to install the app, about 15 to 20 minutes for a clinician to learn how to use it, and they're up and running, and they're really proficient, probably starting around that 30-day mark. So we take them down a documentation journey called Crawl, Walk, Run. And so by the end of that journey, they're documenting at a high rate, their accuracy is super high, and most importantly, they feel comfortable and good about using the tool.
So nitty gritty, how does the contract look? Is this, year contract? Is it per user? Is there a minimum user? How does that work?
Yeah, no minimum user. It's an annual contract with us. So we have tiers of users, 1 to 25, 26 to 50, so on and so forth. We used to do individual pricing per user, but it became very messy. As you know, when you're onboarding, 80, 90 clinicians a month or a quarter, that becomes really messy really quick. So, yeah. And we had a lot of agencies saying, well, I don't know if I'm going to put this clinician on because they only work 25 hours a week, or this one's PRN, so I'm not sure if I'm going to put them on. So we decided to do a tier-based approach where the more you consume, the less per clinician it is. It truly, most, of our agencies are paying less than $1 a day per clinician that uses the system. So really affordable. And again, we're able to do this in a proof of concept to sort of prove it out in your environment to make sure that it works and you feel comfortable with it. You see the value of it, and then you can decide to move forward.
See, and I've always said, and I think for me, I've been on the sales side, I've been on the operations side. I've had a lot of friends, clinical. It's like, if you can just show me what you say you're going to do, then I shouldn't have to worry about it. Show what you say. We're going to move forward. And I've been a part of things, or I've seen things that are outside of the reality of being able to purchase something. It's a great technology. It can do a lot, but we are limited within our reimbursement scope, especially on the home health side. Scrapes every penny that they can get, right? I think hospice still has a little more luxury. But, is it something that is affordable, or what does that look like? You may not have all the answers because, again, it's tiered and what they're based on, but, roughly what is it looking like per user, or for a smaller, medium-sized agency? What is this going to cost them?
Yeah, smaller agencies, about $25 a user a month, and maybe up to $30 depending on if you want to add on our newest feature, Note Assist, to that. Some of our agencies are paying closer to $15 a user a month as their volumes get up there. So, again, wow, we believe that the value is definitely there to go deploy this. Good news is there's no interface fee from Access or many of our other partners. We do the deployment. We're very hands-on, and that's all built into the pricing as well. So you're not going to have to worry about extra fees or anything like that. We've had great partnerships out there.
That's huge. I mean, kudos to Access and anybody that's been working with you. I think that's been a huge barrier to organizations like yourself, that, again, you have this amazing product, and maybe even you can give it to the end user at a reasonable cost, but the interface itself is $50,000 for the organization of any size, just because that's what the cost. I know technology, adoption, and individuals are becoming more and more able to scale this sort of technology faster, but still, kudos to y'all that y'all found a way for these major EMRs to adopt y'all so quickly and not put the burden back on the agency, small mom and pop agency, to be the leader of innovation. Like, it seems right that the EMRs and y'all have been able to pave the way for them. So again, that sounds awesome.
If I were an agency owner, I would look at this as a benefit to my employees. It would just be one more benefit to add, just like health insurance or anything else. I mean, if you can give them the gift of time, what else? I mean, what can improve upon that? I mean, I just think that's just an incredible gift that an agency could give to one of their employees.
That's very sage of you to say. I had a very well-known home health and hospice executive come up to me not that long ago and said, "Jason, you're dental insurance." And I go, "What do you mean by that?" And he goes, "We're a benefit that we think all clinicians should have access to." And, some clinicians will absolutely take advantage of it. They're going to get their 2 times a year cleaning. They're going to get their discounts on veneers and caps and fillings and all those things. But we believe that every clinician should have access to this. And this is a leader in our industry. And I thought, wow, that's a really cool and interesting way to see it. So, Arlene, that just echoes what that executive told me a while back.
Yeah.
Well, and I think as we become more and more focused on compliance, and we're seeing more the admission nurses and discharge nurses, I think, would see the most value in this as well, just because it is extremely rigorous and extremely important that these things are documented appropriately, or they're going to miss out on, entire episodes potentially. If you're going back to the admission date, right? You could lose an entire episode. You could be, $5,000-$10,000 behind, maybe even more in a hospice case, 90 days, 60 days sort of situation. And the government's not going to care if they find something that is wrong. So having that ability to get your information into the system as quickly as possible. In 2023, there's no excuse now not to have something to do that with nVoq, as we know that you've told us, but that should be a focus and probably in a solution that's already solved for your organization. We should not have 48-hour documentation. And I know, Arlene, you go into any organization today, I guarantee you there's at least one nurse that has notes open that are past 48 hours. You could be the best, you could be the best agency, but there's one nurse, and there's no excuse for it with this sort of technology.
Tell us, Jason, what you plan on speaking on at Access. You're going to be one of the featured speakers. And what types of things will you at Agile? I'm sorry. What types of things will you be covering there?
Yeah, so I have the good fortune of speaking with Ray Melton from Access, and what we're going to be speaking about is the transition from palliative care to hospice, and what palliative care means now, what it's going to mean in the future. As we probably all know, there's no standard definition for palliative care. There's also no standard way of reimbursement today. There's obviously fee for service, there's obviously value-based contracts, but palliative care looks different all across the country. The angle that I'll be taking with it is most of the palliative care documentation is still yet very unstructured. So most of the NPs, social workers, people that are providing palliative care, either in a hospital, nursing home setting, or in the home, are documenting patient stories, patient narratives. And so I think it really lends itself to something like speech recognition. Most of the NPs, doctors, PAs, they're used to using speech recognition anyway, which is another thing. Whenever you go to your doctor in the hospital or you go to an ambulatory setting, it's commonplace. I just went to an appointment not that long ago. My doctor pulled out the dictation device, starts dictating right in front of me. I hear exactly what's going in the medical chart. And so, it's becoming more and more commonplace for you as a patient or family to experience speech recognition. And so why not in your home as well? And then, I think this is talked about a lot, within 5 years from now, or approximately that, we're going to be, the dominant workforce is going to be millennials, which is scary to me because that puts me at an age bracket that is very interesting. But they're also used to using speech recognition. If you watch the way that they interact with their own personal devices at home, wherever, they're used to using voice technology.
Yeah.
So for them, this is absolutely second nature. So while nVoq, I would still consider us very innovator, early adopter, I think that's going to, at one point, speech is going to be table stakes in home health, hospice, and palliative care. And then it's about what value can you continue to bring on top of the speech recognition.
Absolutely. And again, I think it's exciting to see that we're able to innovate so quickly. 5 years ago, I think the starting of the speech tech, text to speak recognition in our phones and this sort of stuff, people were being like, oh, that'll never go. I heard nurses say, oh, that'll never. And now we're on the cusp. It's exciting to see what else is going to be in the future. But you said that nVoq is also not just speech recognition. You have a suite of solutions for your customers. How does it all work together? What's y'all's approach for these agencies? You go in, you see that they need this speech recognition, probably a start off a platform, but then where do you go from there?
Yeah, so there's certain pieces of functionality. I talked about one note assist, and so we start to delve into what the issues at the agency are, right? And you hear very common themes, right? Retention, recruitment of clinicians, time savings, but then you start to hear things like, we're really struggling with our quality, right? As it relates to audits, as it relates to our survey process, we're struggling with, getting our revenue in quickly and in whole, right? So we did a recent study that we presented along with one of our clients at a post-acute long-term care conference in Tampa. And, the net of it is that we took this particular organization from a process where they had 15% of their claims at risk of being clawed back because the documentation, the narrative of the documentation did not meet, the regulatory requirements to about 3% in a fairly short period of time. And so again, as you look at, people are thinking of nVoq as a speech recognition company. Yes, we do that, and we're really great at doing that. But we do so much more to impact QA, drive down the cost of QA, make sure that your revenue is protected so that you can continue your mission in the community that you serve, and ultimately impact patients and the patient satisfaction, which, as we all know, is going to become a component of reimbursement.
Value-based purchasing, that's right. 30% of that is going to be the and communication is one of those issues that you mentioned. You mentioned that the HCAPs earlier, and one of the questions has to do with the communication. How does my staff communicate with me, and how do they communicate with me? So this answers that question for them, and they know that the communication is going on.
Absolutely.
Well, and even further than that, accurate information is really the name of the game when you have a team of individuals, and we know a rotating labor force, that you have somebody that's coming in, may have never seen this patient before. They're supposed to read through documentation and get a good overview of who this patient is and how do I take care of them. If the documentation was lacking before, the nurse, even if they're well qualified and they want to do well, is not going to be able to give the care that is needed without the information that was there. And so time, that documentation in the moment and making sure that it's accurate is super important. I just remember laughing at reviewing documentation for my nurses that would do speech to text off of WellSky. I was using WellSky at an agency, and there was like every other big word was totally the wrong word, just because they, heard the software heard something. But these nurses are utilizing this software not because they want to do more admissions or they want to do more visits. It's because they're overworked and they're trying to scale back down to a reasonable workload. So this speech recognition software, this text to speech or speech to text, is supposed to do the job for them. Hardly any of them, and I know some of them do, and I'm not speaking for all of them, are going to go back and review that information over again because they just spent time doing it. So again, it needs to be extremely accurate at the get-go if it's going to take the real burden off these nurses. And it sounds like y'all thought about that. So
yeah, we have. And to your point earlier, John, you put your finger on it. When does the stuff hit the fan, proverbially? It's at night. It's on the weekends. And so you have your after hours or triage team or your weekend team, and they're trying to decipher in a moment's notice, what's the picture of this patient, right? The patient's calling me at night in distress or worse. And now I've got to figure out, I got to search the chart for what's the latest and greatest going on with the patient. And if there's not good quality data there, then the response is just not good, right? And so, those after hours, those weekend nurses, they benefit too from high quality communication notes, because then they're just so much better enabled to go respond to that patient or family when they pick up the phone at 2:00 on a weekday or Saturday afternoon, to be able to respond to them.
Are y'all aggregating data at the high level of all the agencies on maybe keywords that are being used, or are you looking at the data to then flip back around, or how the product's being used to flip it back around again to give insight to these agencies? Is that the goal?
Yeah, that's the goal. I mean, we use it to obviously hone the speech recognition tool. Right. So we want the speech recognition tool to get better and better and better. But we're also looking at across the board. So think about, we're trying to start to benchmark, things like documentation time on narratives by the clinician and by the role and the type of visit that they're making across the industry. So, I don't know if there's really super high quality data about how much documentation time clinicians are spending on narratives per home health admission nurse or per physical therapist home health admission, or per social worker routine visit. And so we're trying to get a lot more data driven in that regards to provide insights to organizations that they don't already know about their organization. And so, yeah, we're starting to look at that data and get much more sort of strategic about how we provide insights back into the customers that we work with.
Just off the top of my head, I was a communications major in undergrad, and we talked about how there's so much more than just the words that people are using that convey or that are able to communicate something. Is something, or have y'all kicked around like tonality in our nurse's voice? Like, man, get a ping on my phone that say, hey, my nurse is having a bad day. Let's make sure she gets like a lunch or something. That would be awesome.
That is really interesting that you said that. So yeah, we're playing around with a bunch of different things. One of them is looking at the tone, tenor, and speed of dictations to tell agencies which clinicians may be struggling consistently. From an emotional perspective, a nonverbal emotional perspective.
Yeah.
And so this is commonplace, by the way, in many other industries, right? There are big organizations that use satisfaction surveys within their industries to really measure that tone, tenor, and speed of dictation as a way of gaining sentiment from their customer base. And so in home health, we think our customers are the clinicians. And so why not gain insight or sentiment into how they're doing based on those nonverbal cues? So John, you put your finger on something that we're actively looking into.
That's awesome. I think it is every tool that we could utilize to help increase the care of our patients is going to be worth every effort. And I've always said that from an administrative operational role, our only job is to take care of our team members, our employees, our clinicians. They're the ones that are generating revenue. They're the ones that are out in the field. If we're able to make sure that they're at 100%, they're going to give 100% care, and then everything else is going to work out. But we have to look at these sort of technologies and these tools and not, I know a lot of individuals that are in this industry I've seen every new tool that's out there and they all say that they're going to be great. And, this is just like that. I'm not going to change anything. I'm going to do it the way I've always done it. But we do have to, evaluate, these technologies. And again, if you're going to put your product out there and say, look, we're going to show you how it's done, there's no risk, right?
Yeah.
You can see that it works.
And some of the best testimonials we've had, John, are clinicians or organizations that were acquired or moved, and they walk into the next organization that they join. They go, where's nVoq? Where's the speech recognition? Right. And so that's been some of the best feedback that, you can't buy that type of feedback, right? Where clinicians are saying, where's the tool that I find really valuable? Why don't you have it?
And I'm not that this is a pretty large topic in itself, but there is more to labor management than salaries. People are going to turn down. We've seen clinicians turn down jobs because they don't have the right EMR, right? So when we have a labor force that Arlene was talking about that is already under constraints of just size and volume and numbers that we have and futuristic projections of where it's going to be. And this is pretty much across the whole industry. Diagnostic techs in general are, we're having problems getting them, ultrasound, nuclear techs, nurses, doctors, everybody. We're having a mass shortage. So, there's more than just throwing money at somebody to get them to want to come to your organization, want to stay at your organization, feel like they're valued in their organization.
100% agree with that. I mean, obviously, I think, paying competitively and having a good culture, they're table stakes. You should have those things.
Right.
But then it's, what are you doing above and beyond? And I often ask the question, how are you investing in your individual clinicians in a systematic way beyond the pay, beyond the culture, right? Don't tell me those things. Tell me what other tools and things that you're giving them that make their life easier. And so, it's a valid point. It's much more than just competitive compensation. I had, the good fortune of working with an organization that paid very well. We had a very good culture, and there's so much more that goes into it than just that.
Absolutely. I think we hit on this over and over again, but I never think it is, something that we shouldn't say, that we should be taking care of our employees. We should be looking for the ways that we improve it. So Jason, thank you so much for coming on the show today and giving us an insight into nVoq. If they wanted to reach out to you, want to get a hold of you, if somebody wanted to learn more about you, what would be the best way to do that?
Yeah, so just shoot me an email, Jason, Jason, .banks, BANKS, at nVoq, N as in Nancy, VOQ.com.
I'll see you in Dallas next week.
I can't wait.
I know. It's going to be so exciting. Those of you who haven't registered yet for Agile, make sure you use the keyword Maxim100 and get $100 off of your registration fee. That's not bad.
No, it's not bad at all.
And you get to meet Jason.
Yeah, there's going to be a lot of great vendors out there, a lot of people trying to be, cutting edge. I'm excited to hear about all of that. And I think we're going to have some pretty cool guests on that week as well. So maybe we'll have you back as well, Jason. You could give us some insights on what your take is of Agile.
Sounds great, John. Thank you both.
Thank you,
John. Thank you, Arlene. Thank you, everybody.
All right, everybody. Thank you so much for joining us, listening to Off the Cuff, all things healthcare. I'm John Kublank. And as always, thank you so much, Arlene Maxim, our wonderful, amazing guest host, and Jason Banks with nVoq. Thank you. We'll see y'all next time.
Bye.
Thank you.